Hi, my name is Kyle and I have bladder cancer. This is the third video in a series where I talk about my experience with bladder cancer and the treatment of my cancer. This third video is about the diagnosis of my cancer and the treatment plan. If you've watched the first two videos, then welcome back, and if you haven't, I suggest you start from the first one. So about a week and a half after my biopsy, the doctor called me at work with the results. He told me that I have stage 2 aggressive bladder cancer with an additional lesion that's a carcinoma in situ. So let's talk about the staging and grading of bladder cancer. So the bladder is composed of 4 major layers. The innermost layer is the bladder lining, and then outside from that is connective tissue, and then a layer of muscle. On the outermost is a layer of fat. So you've got lining on the inside, then connective tissue, then muscle, then fat. So the stage is based on how the cancer has progressed from the inside of the bladder to potentially the outside of the bladder. TA is a tumor that is just in the lining, so it hasn't progressed into the muscle. T1 is on the lining and into the connective tissue. T2, which is what I have, is into the muscle, so it's invaded the muscle of the bladder. T3 has gone through the muscle and into the outside of the bladder, the fat. And then T4, the tumor has gone completely through the bladder and has gone outside the fat, so through the fat. Aside from staging, there's also cancer is also categorized using a grade. So grade 1 is when the cells look a lot like normal cells, and the cancer is growing slowly. Grade 2 is when the cells look abnormal, and they will tend to spread into the muscle wall. And grade 3 is when the cells look very abnormal and they're growing quickly, and they're very likely to spread into and through the muscle wall. So I have grade 3. It's very aggressive. So I have stage 2 grade 3 cancer. T2 highly aggressive. I also have a type of lesion called CIS, or carcinoma in situ. Sometimes that's referred to as stage TIS, and that type of lesion is currently only affecting the lining of the bladder, much like stage A. However, unlike stage A, CIS is flat along the inside of the lining, whereas TA kind of grows like mushrooms or coral out from the lining. And unfortunately, CIS is very aggressive, and it's likely to recur. And it's likely to grow deeper into the bladder. So this was really bad news, obviously, because muscle invasive and highly aggressive means that my bladder has to be removed. So my urologist referred me to another urologist who'd be performing the cystectomy, the bladder removal. And my appointment was that afternoon, just a few hours after I talked to my urologist. So in the meantime, I went home and cried a lot. So later that day, I talked to my new urologist, who specializes in surgeries like what I would need. Before I even said anything, he explained his credentials and his experience. And then he explained why my cancer is so serious. And he explained that complete removal of my bladder and prostate is the only good solution for a person of my age in order to prevent recurrence. So he laid out a treatment plan of another TURB to resect and debulk the tumor, and at the same time I'd have a chemo port installed, and I would need to receive 4 cycles of MVAC chemotherapy to kill any cancer that might be outside of my bladder, and that would be followed by a radical cystectomy and prostatectomy, which is a complete removal of my bladder and prostate. And before I did some research on the prostate, I didn't really know what it did, but it's pretty important. It produces your seminal fluid, so the fluid of your ejaculate, and the nerves around the prostate is what causes you to have erections. So if the chemo doesn't sterilize me, and it will, then removing the prostate certainly will. So my doctor explained that in many cases he's able to retain the nerves around the prostate, and that would allow me to retain the ability to get erections. But even so, I'd have to use drugs like Viagra or injections into my penis to get an erection. He said that the chemo was my option, that removing the bladder and the prostate is a foregone conclusion. They have to come out to save my life. But chemo is an option, and statistically it adds about 5% to the rate of 5-year survival if you have chemo before your bladder is removed. I debated it briefly. I thought, do I really want the chemo? And I did some research and I talked to some folks who have been through it, and there aren't really any long-term side effects to chemo. It's rough going through it, but after you're off the treatment, then everything kind of comes back. So I figured that I'd probably not regret going through chemo, but I might definitely regret not going through it. If later there was cancer somewhere else and it spread, and I wasn't fortunate enough to have a definite treatment for it, like I do with removing my bladder, if it spread to my lungs or something, then I can't take my lungs out. So the doctor and I agreed on our priorities. Number 1 is to keep me alive. He said that without treatment, I'd probably be dead in 2 years, which was a major surprise because I, at the time felt fine. Second, to give me continence and the ability to hold my pee as a quality of life consideration. And third, to allow me to have erections. And I wholly agreed with those priorities. Then we discussed the different kinds of urinary diversions. So there are 3 main ones: an ileal conduit, Indiana pouch, or a neobladder. And there's a lot of information on the web about those, so I won't talk about them here. But the doctor recommended for me to have a neobladder, since it retains most of the normal urinary function. And it happened to be his specialty, which is great. He says he does more of those operations than anybody else in the state. He did mention that neobladder might not be an option for some people, depending on their anatomy. So with a neobladder, they take a part of your small intestine and they cut it out, and they lower it down to the position of the bladder, and sew it together to kind of form a new bladder. And if the blood vessels of your small intestine don't allow you to move that piece of intestine low enough, then that wouldn't be an option. So he says before going into the surgery for a neobladder, he always marks people with a stoma as a fallback. So you might go into the surgery expecting a neobladder and then come out with a pouch or a conduit. But given my anatomy, he said I'm fit and thin, that a neobladder would probably work. So my urologist then scheduled me for an appointment with an oncologist, and about a week later I met with him and his team. So he discussed that there's no good alternative to a complete cystectomy. The bladder just has to come out. Some people try to preserve their bladder because it's scary to lose it, and it definitely affects. I expect it'll definitely affect my life. And he said that if we tried to preserve the bladder, then we would need to add radiation to the chemo, and the radiation would likely scar my bladder so bad that I would be peeing constantly. I'd either be incontinent or I'd be peeing constantly, and it would dramatically affect my quality of life. So the only time they do that, he said, is when a person just isn't strong enough to make it through a cystectomy, because it's such a big operation and there's a long recovery to it. And then he reaffirmed the chemo treatment plan, which is there's two main types of chemo, and they recommended for me the more harsh one because the studies have shown it to be a bit more effective. So that's MVAC. I would need to receive 4 cycles. Each cycle is 2 weeks in length. It's 3 days of receiving chemo. So 1 short day, and then, which is probably less than 4 hours, and then a long day, which is all day. It's like 6 or 8 hours. And then a really short day after that. So 3 days in a row, and then 11 days off. So it's 4 cycles of that, which, depending on my tolerance to the treatment, would last between 8 to 12 weeks. So my wife and I asked a lot of questions, and he answered them all. And then he scheduled me for a few procedures to baseline me before I went into chemo. And that's an echocardiogram to check my heart function, and a PET scan to look for any other cancer in my body, and also a chemo training program to help me know what to expect from the chemotherapy. So those 3 procedures are all relatively short, and I had them all on the same day. The echocardiogram is like an ultrasound of your heart. For me, there was no preparation for that procedure. Sometimes you have to limit your sugar intake, but I didn't have to do that. It was really short. They had me take off my shirt and lay on a table, and it was just 20 minutes of the technician sitting next to me and rubbing the imaging wand across my chest. It was painless. Sometimes it was a bit uncomfortable because you have to hold your breath and remain really still for some periods. But it was actually really cool because I got to see pictures of my heart valves working. I expected, just to get a picture of the heart, like one picture of the outside of the heart, but they could actually go inside of the heart and see each individual valve, and it was really cool to see that. So that was a quick and easy procedure. So I think the reason that they need to have that echocardiogram is to get a baseline for how my heart performs before I go into the chemo, because the chemo drugs can really impact your heart, and they want to make sure that your heart is staying healthy through the treatment. So they might delay some treatments if my heart is having problems, or put me on different medications. So the next procedure I had that same day was a PET scan. A PET scan is an imaging test to see areas of high activity in the body, which is shown by pooling of a radioactive tracer material that they inject into you. So it's kind of like a CT scan. The preparation for that procedure was no food for 6 hours before the procedure. But I could drink as much water as I wanted to. In fact, it was better for me to drink a lot of water to stay hydrated, because it helps the tracer material that they inject move throughout your system easier. So they first injected me with some saline, and then they injected the radioactive material. The saline was weird because I could taste it in my tongue. And then the radioactive material, I couldn't even feel it or taste it. It's just kind of strange that I could detect saltwater injection, but I couldn't detect radioactive material. So after they injected it, I had to wait in a chair for about 40 minutes for the tracer material to move through my body. And then they had me lie on a table, and that table moves through a large ring that allows them to take pictures of my entire body. So basically from my eyes to my thighs. So it took about 20 minutes, and I had to lay completely still. It was slightly uncomfortable, but it wasn't too long. And the ring that they move you through is only about 2 feet maybe in length. So it's not like you're moving into a really enclosed space. So it wasn't very uncomfortable. They got the results really quick. The next day my oncologist called and said that everything looked good. But they did see a spot in my lungs, which freaked me out immediately. But it wasn't a cancerous spot. They asked me if I had a cough, and I did. So they thought it was a touch of pneumonia. So it was pretty cool. They were able to detect that I had a cough and why from that procedure. So they put me on some antibiotics to clear up the cough before I would go into chemo. That same day I had training for the chemo. So my wife and I went to the cancer center where I'll be receiving the chemo and met with a nurse. And they showed us around the facility and answered all of our questions and walked me through the chemo regimen and gave me a huge binder full of information. And they even showed me the port that I'd be receiving so I could see what it looks like before I have it placed in my chest. So now the treatment plan is laid out. So let's do a quick schedule recap. The 3rd week of September is when I first started seeing symptoms, blood in my urine. The 1st week in October, I went to a med check to see a doctor about it. And then she recommended that I go to my primary care physician. So the 3rd week in October is when I saw my PCP. And he referred me to a urologist. So the 4th week in October, I had a consultation with the urologist. A couple weeks later, the 2nd week in November, I had a CT scan and a cystoscopy that detected the tumor in my bladder. The next week, the 3rd week in November, I had a TURB, a transurethral biopsy, to get a diagnosis and then the first week in December is when I received the diagnosis that I had stage 2 aggressive bladder cancer. That same day, the first week in December, I had a surgical consultation with my new urologist. Then the second week in December, I met with my oncologist for the first time. The third week in December, I had chemo baselining and prep procedures. And then I was scheduled at that time for another TURB biopsy and also debulking of the tumor and installation of a chemo port into my chest. That was also the third week of December. And then I was scheduled to begin chemo, the first round of chemo, in the 5th week of December. So all of this takes place in the span of about 3 months. So I went from seeing a bit of blood in my urine to starting chemo within 3 months. So that kind of moves me into my lessons learned for this video. The first one is, things really happen fast once you start seeing symptoms and you start seeing doctors and get a diagnosis. So be ready, because things happen really fast. And I kind of felt like I was just along for the ride. I just do what the doctors tell me to do, and I show up when I have to show up, and I'm mentally ready to take on the treatments. And that's kind of the role I see as a patient. Let the people do what they know how to do and be ready for it. But educate yourself. So I did a lot of research ahead of time to have an idea of what the doctors might say, so that when they said it, I would be ready with questions, and I would have some context to understand what they were saying. In those consultations with doctors, definitely bring along another pair of ears, because some of the stuff that you talk about is really difficult to grasp as the patient, and kind of shocking. So it helps to have a second pair of ears that can hear what the doctor is saying, while you as a patient are busy feeling what the doctor is saying. So bring somebody else along in the consultations, and take notes, because it helps you internalize, or it helps me internalize and keep track of things.